Demonstration of a case of interno-external hemorrhoid treated with a treatment modality called as hemostatic hemorrhoidectomy, a modified Milligan-Morgan open hemorrhoidectomy. Here there is no single drop of blood you can see in this operative procedure. Now just see the procedure. Local anesthesia, lignocaine with adrenaline is infiltrated at the perineal region at the lower part 6 o'clock, half centimeter away from the anal verge. We have to infiltrate around 1 to 1.5 cc. Slowly withdraw the needle, and then direction of the needle is changed to the opposite side at 9 o'clock position, and the local anesthesia is infiltrated. The direction of the needle is changed towards 3 o'clock position to create the first V limb, and then infiltration after this. In this way we have to create a V limb, and now we are going to take one more prick at 12 o'clock position. In a straight direction we have to give 1 to 1.5 cc, and again changing the direction of needle, making an inverted V shape towards 9, and then towards 3 o'clock by changing the direction of the needle we have to make an inverted V. This is going to complete the rhomboid shape, means V and inverted V is the rhomboid block that we are going to complete the local anesthesia, that is called as perineal rhomboid block. Slowly stitching of the anal canal is carried out. 4-finger stitching of the anal canal is made to compensate the fibrosis which is going to take place in a post-operative period. And after that a pile mass is caged, and the base of the pile mass is transfixed with barber linear number 20 with a round body needle of number 6, and then we have to complete the transfixation on both the sides. First we have to tie at the base of the pile mass. This is called as a high ligation at the upper pole, and then we have to take the, as the pile mass is an interno-external, we are going to put a hemostat, that is the artery forceps, by taking the margins, entire margin of the skin which is protruded out is made trim by application of the appropriate application of the hemostat, that is the artery forceps. So that hemostat is going to maintain that even after the cut it will not bleed. Now I am using the cautery machine. Now slowly we have to begin the cutting, not in a V shaped, but only up to the restricted to the skin which is protruded out, that is the external part of that hemorrhoidal mass. So interno-external hemorrhoid, in this way we have to slowly cut the pile mass with the skin of the pile mass, the external most component, and then while reaching to the, after reaching to the mucosa we have to stop, and then we have to complete the ligation here on the outer edge where the skin has been, or the external component has been excised. Now I am going to complete with 2 knots. And again for the safer side, the second round of the ligation is to be carried out. Upper pole of the base of the pile mass with 2 knots, and then on the outer edge where we have made the edge, there we have to complete it with the 2 round completion without single drop of bleeding from the. So this is nothing but a open hemorrhoidectomy only, but the modified Milligan-Morgan technique we can say, and we can see that there will not be any bleeding from that area because we have used that forceps, the hemostat, which is going to perform its hemostatic work without any bleeding. And then I am going to excise here the external component first, which is covered with the skin, and then The internal hemorrhoid, after leaving some part of it, the proximal part is going to be excised here without a single drop of bleeding. So this is going to complete the hemostatic hemorrhoidectomy, and after that we have to again the cautery machine with a coagulation end, we have to trim it so that it will not give any mark over there, and post-operatively it will not pain. So this completes the hemostatic hemorrhoidectomy under rhomboid block.